Hey, what up? It's Elge, and it's Simple Lines Anatomy, and this is our sacral video, part 2. I'm not saying the full name, Clark, deal with it. This one is hot, this one is exciting. We're so excited. It's going to be a solid 6 out of 10. It's going to be fantastic. Let me get rid of a few layers here. Get rid of that 2, get rid of that part 1. Clear that stuff, clear that. Anyways, last video we're talking about a few relatively simple concepts. Simple as we could make it. And we were talking about how the muscles change the position of the sacrum to some extent, but more than likely what it is the paired actions of the spine and the ligaments and the innominate, the big hip bone attachments, and how those all interact together. And so we're going to continue on with that, just as I get rid of these layers. I'm going to continue on with that idea and explain some of the more complicated motions that come out, because in the previous one we just talked about generally flexion extension of lumbar spine, general changes in pressure on the leg, and general changes of the innominates as they turn and they twist. So we're going to talk more about compound motions. So the first thing we're going to say is, in the last video we talked about how the sacrum was affected by the lumbar spine. And if I could just get there, that's perfect. 12, got to go with the 12. So let's say the lumbar spine goes into extension. It goes relatively anterior forward. This should, by all means, put more pressure on the front of the body, more pressure of the gravity line, center of gravity, whatever you want to call that. It should change it to the front. And because of the fact that the sacrum itself has a bit of a 45 down, if you look at it close up, there's that sacrum from the side, really close up. Notice it's on a little bit of an angle, an oblique angle of 45, whatever you want to call that. But notice it's on a 45. And when you start putting pressure on the front of it, start pushing pressure here, it tends to tip forward. This is an expected thing. So as it tips forward, for instance, it tips forward this way, it's called nutation. Throw an N in there. Nutation. And should be that if one side's going forward, the bottom part is going backwards. We say that's nutation. Because they're connected, that's how they work. In any case, now we want to throw a couple more things in there, because it's not just a simple matter of there being extension. It's never that easy. That would be lovely. But if we want to really make a problem out of this, and you know, that's the most fun part, solving really big problems, we need to add a few more elements to this. So let's say instead of just a general extension of that lumbar spine, we actually had a few elements of side bending and rotation. Now, it's known that the lumbar spine is not much of a rotator side bender, and that's through like L4, 3, 2, 1, for sure. Agreed with that. But L5, that guy right there, does a lot of really good, really solid side bending rotation. It's made to do it through the facet joints. And so it can do that quite well. There's those facet joints we were talking about. And so there's a ton of side bending rotation. So we're going to arbitrarily just pick one. We're just going to say it's side bent to the right. So it's side bending like so, and the axis is an anterior-posterior axis. It's about straight through the middle, give or take. And it's pivoting towards the right. It's bending towards that right on those facet joints. And so that means now we've shifted the body's weight just a little bit. Now, it could be that more of the weight is to this side. It's possible, but for the purposes of this example, just to make it clear and make it understandable, we're going to say more of the body's weight is pressuring now here, and it only needs to be a little bit more. Of the body's weight needs to be a little bit more on the right. Even if we reduce that load quite significantly and we only have it slightly over, we just say that that body's weight is more on the right now. So consider for a sec, if the weight is what brought on the nutation in the first place, this gravity line being anterior brings on the nutation. It means that if there's more of that forward weight, it's both extended and side bent, there's more weight on one side, we should see one part of that sacrum tend to go more forward than the other. Okay, so now we're getting somewhere. We're getting extension, side bending, changing and directing that pressure, therefore changing and directing the position of that sacrum. Now, here's the thing. It's never just extension and side bending. There has to be something else. In the vertebra at this particular area, it's side bending and rotation together. So that rotation tends to come in, provided the extension is not too extreme or provided it's not an extreme flexion, tends to come in and we get the opposite rotation. We get what's called rotation to the left. So let's throw up a vertebrae there just to explain this, because this is it can be a difficult concept. It's not super difficult, but understand this is that's a cartoony vertebrae. That's not bad. Anyways, vertebrae here, what we call rotation to the left is by pointing the vertebral body. So if it's rotating to the left, it's doing this thing. And I'm just going to pick up that whole thing through the magic of technology and grab that up and just turn it to the left. So you see how that's now rotated to the left, and we dictate that based on the way the body is pointing, because the body of the vertebrae, that front round part, is now pointing to the left. Now you could also say that the left side is back here, and you can palpably feel that transverse process a little bit better. It's sticking out a little bit more, but we really call it based on the body. Pretty sure I'm right on that. I don't know. Correct me if I'm wrong. Pretty sure. Anyways, so as it rotates, there's some other things that happens as it's rotating backwards towards the left, or you could say the right side technically is rotating to the front. Either way, we've got some connection points here. So there are lumbosacral ligaments between the lumbar spine and the sacrum. There's multiple bands, but in any case, there are attachments between the two. So consider for a second what happens when you start to pull on those attachments. As you start to pull on the attachments, as this rotation comes in here, it means that those same ligaments on the left side, this being the left all the way over here, these ligaments are being pulled along with it. So as the right side is being pulled forward, technically, the left side is going to be pulled backward, or at least pushed backwards. Pulled, pushed, kind of the same thing almost in this scenario. So we get a dropping forward more so of the right side with that extension and side bending. With the rotation, the left side is going to be drawn back just a bit, just enough, and it's going to be through those shared ligaments. And so this starts to bring on the appearance of what we might call a shear. Now, just to clarify, understand that this vertebral rotation, it's not necessarily that this is instantaneous. This can be a bit of a misconception, because this can be generated really slowly over time. So as this rotates through this region, as it starts to pull on the ligaments within that area, the ligaments attaching from about there, and starts to pull in between the ligaments between the sacrum and the lumbar spine, it might not be an immediate and extreme pull, but it might just be that now that we're positioned in such a way that favors rotation towards the left on this side, it's gradually favoring that movement more so within that region towards the left. So the sacrum is just more and more pulled back on the left, and on the right side it's pressured more and more forward. And so we get that motion. It could be the exact opposite thing going on somewhere higher up in that 11-12 region, which is really good for rotation, or in the AA region, for instance, the atlantoaxial joint. That could be doing the exact opposite. But within this region, it's definitely doing that. So it makes it appear, and you can call this whatever you want, but it makes it appear as if this side was more stuck, this side was therefore going forward. And it's almost as if there was an axis through there, a rotation point through here. And so it's like this side's also coming back at us a little bit. In technical terms, in sacral diagnostics, tend to call that a shear. And so notice this is something very much being driven from the top down. This is coming from lumbar spine down. And this is a very important distinction, because it's not sacral alone. And it doesn't necessarily require sacral attached muscles. It will be sustained by them, of course, but it doesn't require it, because that lumbar spine extension, just for reference, that lumbar spine extension can be generated by the psoas muscle, which would be attaching there, and it could certainly be generated by the erector spinae muscles, which do have a sacral involvement anyways. And then the deep intrinsic spinal muscles could help with that too. So all of these things can do that, but they don't necessarily directly influence the sacrum. Not as much as you would say, as we made the example of intervertebral joints, the tibia, or the elbow radius makes a good example. Okay, so that's top down. I want to make just another example. We're going to go from the bottom up and see how we can kind of create the same thing Potentially. There's lots of different ways to do this. There's not only one way, and what I say is a potential. It's not an absolute. So let's say, for instance, we get a big adductor pull. Adductor magnus, adductor brevis, adductor longus. Cool. We're all good there. I don't think that's proportionate, but whatever. You get the idea. Anyways, we got a big adductor pull, just for instance. And that will pull on the pubic bone. The pubic bones right here, this is our superior view, a very deconstructed version of it, but it's pulling essentially in this direction. I'm going to erase that just for clarity's sake in just a second, but just understand the adductors are going to pull because the hip joint is approximately here and the femur is approximately there. It would, I'm drawing it a little bit flexed, but kind of more or less like that. So the direction of pull is on the innominate, and this is a movable joint. Despite what some people might say, this pubic symphysis is actually movable throughout your life. It's not movable a lot. It's not as movable as your knee, but it's still very movable, so we have to consider that. So what that can do is, as it pulls generally that way, it's going to pull on that innominate, what we call the ilium, ischium, pubis, all that fused, because they're attached. They're all the same bone. So if that's the innominate iliac part, it's going to pull it forward because it's going to drop down. So looking at it from our front view again, so we're saying this is on the right side. So as it drops down, it's being pulled in more this direction. There's that adductor magnus, for instance. As it pulls it down, it's going to pull it here too. They're one fused bone. It's continuous the whole way through, all the way top to bottom, left to right. It's all one bone. It's fused. So anyways, if the pubic symphysis drops down, it takes the sacroiliac joint with it, and it tends to rotate it forward. This is what we could call an anterior innominate, for instance. Now I'm going to give another slight variation to this, just to make it just a little more plausible. And we could go the exact opposite way and be totally fine and make it just a different diagnosis, but I want to just make the same thing from the bottom up. Let's say we get adductor, ADD, adductor firing, and it not only pulls on the innominate, but it also adducts the leg too, because that is actually the point of the muscle, so it starts to adduct the leg. And if it does that, it probably means we're going to bring the hip muscles, say gluteus medius, minimus, TFL. You get that TFL in there, and it starts to pull down on them too. And so we get another angle of pull. So it drops the innominate this way as if it was more of an AP axis. Now what that should do at the level of the SI joint, it will create a little bit of a gapping at the top. It'll do just a tiny bit of that. It doesn't need to be much. The sacrum only moves 1 to 6 millimeters, give or take, but it gives a little bit more space. So where there was a tiny little bit of space before, there's a lot more now. And on the opposite side, just always remember, there's a backing to the innominate. That iliac area will kind of cover it up a little bit. So now this side is uncovered. This side over here is a little less covered by the innominate. And it means that even though I'm not directly pulling the sacrum through muscles, it wants to fill that space. 2 reasons. Easily because we've got ligaments attaching here. So if we gap and we start to stretch those ligaments out, we start basically doing this with it, it's going to try and fill that space. It's going to try and rock back into a rotation back on the one side, and it'll be mostly in the top corner because the top corner has been freed. So here we have more space up here than we do down there. So we're going to see the top corner of this thing. I've drawn it on the wrong side. There we go. We're going to see the top corner of this thing come relatively backwards, and that means the other side is going relatively forwards. So this is the case. So it's ligamentous stretch is a possibility, getting the right side to come back. But we also have just the fact that the bone wants to fall into the gap that it's given. There is a lot of pressure in this pelvic area. Every time you breathe, there's a ton. You've got important organs that move things through it, depending on how you're made and depending on what you eat, if you get my drift. And so it means that the sacrum is being pushed back on a regular basis. It is part of the reason why it has reinforcement on the back of it, for starters. But at the same time, if we just give it a little more space, it's going to generally fall back and create that right side motion. So these are just 2 possibilities. Just to be clear, we could make a lot more easily spend a ton of time on that, and that is fun. But for purposes of a video, we don't want to spend too much time. We've also got one more thing to cover, so let's get rid of some of this. We're just gonna delete that, get rid of all that. Okay, so we wanted to talk just briefly about specific adjustment. We say brief on purpose. We're keeping it very general here. So let's assume you've gotten rid of all the other stuff. So this sacral extension, you take that away, fixed, everything is beautiful again. You know, you take away any inanimate stuff, everything's clear, we're all happy there. We take away all the sacral problems from the outside in. Femur, perfect, beautiful, great job. Okay, you did your work. Awesome. But the sacrum can still be stuck. So the deal with any bone is that its environment is probably what makes it move to some extent. And in this case, we're making a very specific point to that. So the environment of the sacrum, we were saying the bones that attach to it and the ligaments that attach to it create the lines of pull necessary to generate change in it. And when that's the case, we have to have something to stop it. Now, in this particular case, we want to say that it is the ligaments that'll stop in a big way. We also want to make a little bit of an example of the pelvic diaphragm, or what we call the pelvic floor muscles, and that's important too. But the ligaments for sure are the end ranges of the motion. They make for certain that the sacrum does not go past its absolute max, because if that sacrum does go past its max, it's going to start to shear nerves, quite literally. It would be catastrophic failure of the system should that happen. So there's got to be something to really stop that, and the ligaments tend to be those things. So it doesn't matter where you are, there's going to be some kind of ligamentous input, and the sacrum is no exception to that. So consider for a second if those sacral ligaments, the things that cover and protect it, just happen to be too short. They just happen to be not long enough to allow normal range of motion. They are supposed to be there as a protective mechanism. Of course, they're supposed to protect it from moving too far dangerously, but what if you could create a state in which those ligaments were too short for seemingly no reason? You would give it the essential state that it's not able to move in any direction now. And so when you look at some of these ligaments, whether we're looking at the anterior longitudinal ligament, whether we're looking at the sacrotuberous, sacrospinous, or the proper sacroiliac ligaments, we need to look at them as threaded, fibrous elements. So the thing is, if you want to reduce the motion in a ligament, you make it too short or too long. Either way, too short, and it will tend to want to occupy that space. It will tend to want to shorten up simply for the sake of stability. If you're putting the sacrum in a position, forced or not, putting it in a position where one ligament is slacked, it will tend to activate its contractile, minor as they are, contractile abilities, and it will thicken, fibrose, and make sure that joint stays stable. However, on the other hand, if your ligaments, for whatever reason, are put on too much stretch and strain, they will tend to thicken and fibrose simply for the purpose of avoiding tearing and avoiding excessive laxity. There's a certain point of no return where you can overstretch something to the point where it is not effectively restorable, where the laxity is there, it's too stretched out, or it can be so fibrosed that it is scar tissue and calcified. But the fact is, we can make it so that the sacrum is then stuck, for all intents and purposes, stuck within its own local area. So no movement here, no movement here, no movement here, no movement here either. And this can happen in the pelvic floor muscles too. Again, talk to a pelvic floor specialist. They really know their stuff. So in a really simple way, let's give just give a few examples. So I'm going to erase some of these pink lines as much as I like them. Get rid of all of them. There we go. So let's give a real easy example. Let's say this sacrum goes forward into nutation. We're going to keep with that theme. If that side's going forward, if the top's going forward, it means everything on the underside tends to go on stretch. So a really good introduction to the pelvic floor is simply that the sacrum is going this way. The bottom, therefore, is going back. I'm going to get rid of that. And therefore, the pelvic floor muscles are being stretched along with it. Pelvic floor muscles, but also we have these ligaments right here. That's our sacrotuberous and sacrospinous. Looking at it from this angle too, from the back posterior side, as this is going forward, this is going backwards. That means these guys are stretching out, both these and the pelvic floor. All of that is going on stretch. So let's say that's stretched. So they tend to want to thicken. They tend to want to add a bunch of fibrous tissue, and that's collagen, elastin, ECM basically. And if severe enough, it'll add actual fibrin to it. And so that makes it hard to move. It makes it hard to actually get these tissues moving again. But as well, that's the long side. Let's consider what the short side is. So if I've got a nutated sacrum, it's going that way. It's got to be something in the back that will hold it. This part is the thicker part. This is the part, let's say, that covers the area between the spinous processes, the interspinous ligaments, the intertransverse, and some of the ligamentum flavum here. So looking at this again, we got all this back here. Same image, just from a slightly different angle, or same image, just from a slightly different angle. This will become thickened as well. So you can use the angles and the threading of these fibers to dictate what you're going to do about the problem. And that's how it should be. You should figure out where the problem is first and figure out what you're going to do about it based on that. Anyways, hope that made sense. You have a great evening.